Very good afternoon to all of you, and thank you for having me here again. And the topic that I got is really interesting. It's about CMV reactivation in the ICU. So, as an infectious disease physician, my relationship with CMV is, not very good because I really don't like this virus. And most of the times, I encounter this during transplantation, where the role or its harmful effects are pretty well defined. But in critically ill, I would thank the organizers to give us this topic, because then I could review the literature on this, and unfortunately there's not a lot of literature. So before I go on, just wanted to understand if people routinely check CMV in their critically ill patients. Like, with a show of hands, if anybody could say, if you routinely suspect CMV in critically ill patients. So generally I don't see a show of hand. So let's talk about CMV a little bit. So it's one of the largest viruses associated with human infections, initially found to be associated with infectious mononucleosis, can cause a wide variety of clinical syndromes. Now, in immunocompetent individuals, it's generally not a concern, but the immunocompromised host is an evolving concept. So traditionally, it has always been considered that, transplant patients, chemotherapy patients are immunocompromised. But as we all know, with prolonged ICU stay, immunoparesis sets in, and that probably leads to profound immunosuppression in these patients as well. Now, most commonly affects immunocompromised patients. Reactivation is more common than a new infection, probably pretty much like this person, who's otherwise a nice man. But if he gets an opportunity, he wouldn't leave you, right? And the knowledge gap really lies in the critically ill patients that I'll try to address with whatever evidence and time we have. So the incidence is pretty wide, 17 to 33% depending on the test used. So because there are lots of assays that are available, some people use IgM to diagnose CMV, which is absolutely not recommended. Earlier, PP65 antigen used to be checked, which is again now becoming obsolete, and then the PCRs. So even with PCRs, there are certain important caveats that I'll discuss during diagnosis of CMV. The risk of reactivation increases with the duration of ICU stay, and then there is obviously higher mortality. So this you can see that the risk of reactivation. So this study just compared, this meta-analysis just compared the incidence of CMV reactivation with critical illness, and you can see that all studies kind of suggest that critical illness or ICU stay is associated with CMV reactivation. And if you look at the incidence of CMV with days into the ICU, so days after entry into the ICU, the graph on the left, you can see as the day increases in the ICU, the probability of a person becoming positive also increases significantly. And this study also gave a breakdown on the type of ICU, burn, trauma, medical, and cardiac, with burn ICUs having the highest rate. But of course, the sample size are limited, but the point is well taken that more the duration of ICU stay, higher the chance of having a CMV reactivation. And also if you look at the viral load, so if you see when the viral load increases with time, the probability of somebody dying in the hospital, in the ICU also increases. So what we know is prolonged ICU stay is associated with higher incidence of CMV reactivation, and a higher viral load is associated with mortality. But the point is this the cause or the effect? Is it the critical illness which is leading to CMV reactivation, or whether CMV reactivation is contributing to the critical illness? Probably the answer is both, but why it is important to address is because we eventually want to know if we can do something about it. So this is just a basic pathophysiology where you can see that any patient who's with sepsis, they initially have an inflammatory phase, which is followed by an anti-inflammatory phase. Patients generally go into immunoparesis, and that can actually lead to CMV reactivation. It can have its own direct effects where you can actually suspect a syndrome such as CMV pneumonitis, gastroenteritis, there could be cytopenias, other end organ dysfunctions, which could be related to CMV, or the indirect effects, because it's such a complex interplay that immunoparesis or immunosuppression leads to CMV reactivation, and CMV reactivation itself leads to further immunosuppression. So it's like a vicious cycle which is sometimes very difficult to get over. And then eventually this is all going to contribute to mortality. Now, the risk factors that have been identified, so it's more or less all over the place. There are multiple studies, small sample sizes. None of them have, systematically evaluated things. But whatever logic suggests that should be associated with CMV reactivation is actually correct. So, a higher disease severity if the Apache or SOFA score is high, prolonged ICU stay, presence of sepsis, septic shock, mechanical ventilation, steroid use, renal failure, blood transfusions. So blood transfusions, they have hypothesized that sometimes with non-leukodepleted blood transfusions, you can give CMV to the patients, but those are very, very, not very strong pointers. But of course, these points that I've tried to highlight in red, they're significantly associated with CMV reactivation. And the clinical features, so cytopenias, again, so whatever I say is so non-specific, because in critically ill patients, there can be n number of explanations for all of this. But when we don't find an appropriate explanation, sometimes which we attribute to non-specific systemic inflammation, sometimes it might be worthwhile doing or checking for CMV, especially for end organ dysfunction, where you might actually consider treating the patient, because that is where the interest is. So one of the things I would highlight is diarrhea and pneumonitis. So sometimes this hospital-acquired pneumonias, bilateral pictures, ARDS kind of a presentation, everything is negative, biofire is negative, so it wouldn't generally pick up CMV. So if you're suspecting CMV, you have to ask for the CMV PCR in those cases. Similarly, gastroenteritis panels, the commercially available panels do not have CMV in them. So if you're suspecting CMV, you must ask for CMV separately. Diagnosis. So PP65 used to be an antigen immunofluorescent microscopy where they would check for staining around the nucleus of the WBCs, but it's not done, it's cumbersome, less sensitive. Gold standard for end organ disease is biopsy. So ideally, if you're suspecting colitis, pneumonitis, if you take a biopsy, it should be positive for viral inclusions on histopathology. However, the test of convenience or the test that is readily available thanks to COVID, everybody does PCRs these days. Initially qualitative PCRs, now quantitative PCRs have also become pretty much readily available at reasonable costs. So we can go for quantitative PCRs. Now these tests are pretty easy to order, but very difficult to interpret. So I get a positive result. I really don't know what to do with that positive result, because what if the copy load is 500? What if the copy load is 5,000 or 50,000? How is the patient different? What is the cutoff to treat the patient? That is not defined. Now it is very well defined in transplant population, both in HSCT and solid organ transplant. But in this particular patient group, we really don't know. It could be anybody's guess. Somebody might think that with a 1,000 copy, my patient is sick because of CMV reactivation. Somebody may think that even a 10,000 load just reflects asymptomatic reactivation. Probably we don't do anything about it. Also, the sample that you choose is important. It should be plasma and not whole blood. If you're doing whole blood, you have to be a little careful. Every time that you repeat a sample, you should repeat the same sample for comparison. Now, on an average, the difference between the plasma and the whole blood CMV copies could be 1 log. So 1 log means it could be 1,000 on whole blood and it could just be 100 on plasma. So that is how much of a difference can be there. So it could look significant when it's 1,000 and 10,000. So 1 log difference can be there with whole blood and plasma samples. Always use the same sample, same lab and the same test for following up your patients with CMV. So what I want to discuss over here is CMV reactivation is probably not uncommon. So just for the last 1 week while I was preparing for this topic, I discussed with critical care team and we just ordered it for 2 people just to see what it is like, and both of them had like 5,000, 6,000 copies per ml. We didn't treat it. Both the patients were terminally ill, and what we thought is probably it can also work as a prognostic marker. It generally indicates a severe illness, severe immunoparesis. Probably that way, at moment, it might have a role. If you think that CMV load is significant, consider treatment, but very, very carefully. So very carefully select your patients. Antiviral treatment comes with cost and adverse effects. You can use ganciclovir, valganciclovir, everything has to be renally adjusted. Refractory resistant cases most likely you will not come across because the patient probably wouldn't last that long with that kind of a presentation. And there are other options. 2 consecutive PCRs, you can aim for negative PCRs when you decide to stop the treatment. There's generally no role for prophylaxis. Studies have looked at it. And at the end, I will just say the CMV is a virus that never leaves. It just takes a sabbatical. And you have to be really careful whether it is truly back or it's just lurking around, and whether you should treat that patient or you should just leave it as it is. But with that, I'll conclude. Thank you.
I have a quick question.
Yeah.
How do we go ahead with CMV positive donors for a CMV negative recipient usually?
For solid organ
Solid
transplant,
organ transplant.
so CMV positive donors with CMV negative recipients. So these will classify as high risk patients. Now in our population, generally it's a little less likely except for pediatric transplants, but still patients who have a D plus R minus status, it depends on the type of organ transplant induction that is used. Most patients will require, like all patients will require prophylaxis. Standard of care used to be valganciclovir. Now with letermovir being available, there's good data in kidney transplant, upcoming data in heart and lung, where you can use letermovir as well. But all patients will require prophylaxis.
Duration is same?
Duration depends, sir. So for lung, generally it's pretty high risk. Some people might go on for years. Some centers might practice very long term because there's now this new concept of checking for T cell recovery. So instead of going by fixed duration, what they're doing is they're checking for CMV specific immune response in the patient. If that's present, they tend to stop the prophylaxis. But generally 6 months to 12 months, depending on the organ type, would be the duration of prophylaxis.